Well, good morning, everybody, and good afternoon and good day to all of you. This is your host, Lalitha Ramamoorthy from Hikigai Studios. Hikigai Studios is actually a great avenue where we would like to bring thought leaders, healthcare professionals, and many other industrial, expertise who bring in a lot of value in terms of what AI has been doing for healthcare and how involved and how deep that we could go into some of these conversations. It is very exciting that I have a very special guest from United Arab Emirates today, and he's someone who has been at the intersection of clinical medicine and digital health for nearly 2 decades and has watched the entire arc of healthcare AI go from hype to high stakes reality, which I think definitely speaks volumes in terms of being able to get his perspective. Dr. Ramy Azzam is a physician. He's an executive born and raised in UAE, trained in internal medicine, and now one of the most credentialed voices in digital health governance. He holds an MBBS degree, an MBA, and this is from the Geneva Business School, a Master of Public Health from King's College London, and the certifications go on and on. I would be spending a whole podcast talking about his accolades and his achievements. He's also led telehealth programs across Middle East, Africa, and Europe, scaled virtual operations during COVID-19, and today runs Ethical Labs, where he works with health systems and governments to implement AI responsibility, ethically, and in the ways that it actually should be. What I love about Ramy is that he's not just an AI cheerleader, he's not a skeptic, but he's also a practitioner who already asks the harder question. Just because we can deploy this, should we? That brings us Dr. Ramy Azzam. Welcome to the show, Ramy.
Thank you very much for the very kind introduction. I wouldn't have put it better, but thank you for having me.
Absolutely. Pleasure is ours. And that's truly what we want to bring into Hikigai Studios, the insight and the thought leadership and more deeper thoughts about how AI is influencing healthcare. And you are in the crux of a place which AI certainly is at its best. So, I'm going to jump on to some of these really intriguing queries for you. But before that, besides the fact that I've given a brief introduction, is there anything that you would like to share about just being in this field to begin with as an introduction, Ramy?
I'd just like to say that this is it's an exciting field to be in. And it's, despite being in it for, as you put it, more than 2 decades or close to 2 decades, in the industry, we still say that it's in its infancy phase. Or I would like to put it that it's a toddler at this point, a toddler that's just learning how to walk and maybe just taking their first steps into running. But in the last maybe 3 to 4 years, that toddler has kind of gained some superpowers. And just to just mention the elephant in the room, it's artificial intelligence. The exponential growth of the capabilities of artificial intelligence models. And obviously, when we say artificial intelligence, everyone's minds go towards large language models, but we're not talking about those only. We're talking about foundational machine learning models and deep learning models. These have grown also exponentially over the last 4 years. Large language models have been a catalyst of that growth. But it's exciting and it's also scary. That's why, as you put it, it's becoming, and this is something that I'm very happy with, and I'm glad that the awareness about the need for governing artificial intelligence is there, and hopefully there will be more awareness into understanding that governance is not the opposite of innovation. In fact, it is the catalyst for innovation. And without, and the analogy that I like to use, if you have a sports car like a Ferrari or whatever, you can't drive it unless you have a very good braking system. And that's what I'd like to say about the domain that we're in. It's an interesting, exciting domain, but it's also riddled with lots of challenges that hopefully we'll be able collectively, obviously, to tackle.
Well, just one more addition to that with the Ferrari. If you don't have well-paved roads, you're going to damage the wheels
True.
and the rim of the car.
True.
And you are one of the pioneers who's kind of paving those roads for well-paved and a very well-constructed road. So kudos to you, and
Thank
here
you.
we go.
There you
So
go.
we're talking about designing Care Without Borders. That's what we call our entire title conversation. When we say care without borders, right? Are we talking about a future vision or something already that's happening quietly today? I know you've kind of touched upon this in the introduction,
Yes.
but go deeper
Well,
into that.
to put it very bluntly or very simply, it's both. It is happening. Care across borders, or cross-border care, as we'd like to say, it is happening. The technology is there. It's mature enough, as we mentioned. It's mature and it's growing exponentially. We are lucky in this part of the world that we're also a young country, a young region. So we're able to build those frameworks accordingly. We're not burdened by legacy systems. But despite all of that, unfortunately, and this is a global and a universal phenomenon, is it's not happening for reasons that are outside the scope of technology, regulation, frameworks. And to put it in one word, it's the incentives. And this is,
Mm-hmm.
again, something that I try to work on in terms of like public health and behavioral health, the incentives to drive most or all stakeholders in that ecosystem to adopt. And these are not new challenges in any innovation. There's always hesitancy and resistance to adopting innovation at first, and then there are early adopters, and then the curve of innovation. That's where we're at. We're still at that early curve where there are early adopters in terms of even providers, and we're trying to get more adopters, because the use cases, the success stories, they're all there, but we just need to get them out there and get stakeholders to understand them, digest them, and adopt them. Yeah,
Absolutely. And the championing is very important too. And especially
100%.
people like healthcare professionals, when they speak the same language and the lingo, I think that's really when that fear, the inhibitions, and many ambiguities would clear over a period of time. Very
Thank you.
well put. Thank you so
Thank
much,
you.
Remy. Leads us to the next question. What is the most invisible border in healthcare that patients feel but leaders often ignore?
I would say maybe we use the word border and barrier interchangeably, and it's not to be philosophical or anything, but we talk about this in the clinical domain. Everyone in digital health also talks about this, and I can summarize it in one word: it's time. And this is a problem that is universal across the healthcare value chain, not just virtual health. Time is a border that is it's a very rare currency, and it's required, but there is a glimmer of hope, and there is a glimmer of hope, at least in the jurisdictions that I work in, where there are, and you probably know this as well, put it in very technical terms, there are codes and CPT codes, for example, in virtual health that
Mhm.
incentivize spending more time with the patient rather than having that constant churn or constant turnover of patients, or having constant turnover for volume. And this is a good step. It's a great step towards basically breaking down that border, which is time, because the doctor or the clinician or the provider, they want more time. The patient wants more time, and it's a no-brainer when patient and the doctor spend more time, or the patient and the clinician or the provider spend more time together, quality goes up. And that's we try to put it in terms like value-based care, and paying for quality and all of that. But I think time is at the core of all of this, and it's the border that we need to basically essentially bring down.
Absolutely. You know, it's interesting. You're just kind of a magnet pulling out all those words that I have in my mind. Value-based care, MEEP score, adding more of the CPT codes that really worthwhile
Yeah.
and brings more value and incentives, as you so rightly said, to the
Yes.
doctors to make them adopt something like this. Because lo and behold, the promises made to them are not all kept, and we still have a broken system in many places. And the United States is definitely a good example, being one of the most strongest. We still have a very shaky healthcare system. So yeah, that definitely brings in a lot of perspective. But I love the fact that you just put in one single word, quote unquote, time. Fantastic. All right. So do you think global healthcare systems design care around their geography or around the patient lives? And that's probably no longer stays in one place. This is a broad question, I know.
Yeah, I think if you ask anyone, they'll know the answer to this. Unfortunately, it's designed around geography. And again, unfortunately, it's something that healthcare systems or providers, they keep talking about patient-centered care when that's the last thing they deliver. I've seen providers that are physician-centered. I've seen providers that are, payer-centered. I've seen providers that are, you know, provider-centered, obviously, like commercially centered. And unfortunately, it's the patient who's the most important stakeholder. The most important stakeholder in that ecosystem is is often ignored. So to answer the question, obviously, most systems are designed around geography, even in terms of jurisdictions and regulations. And that's obviously one of the borders, because you talked about borders. I mentioned time is the most basically omnipotent kind of, or omnipresent border. But then there are other borders, and one of them is obviously geography and for virtual care or cross-border care. It's one of these borders that we need to bring down as well.
That's interesting. I was in a conference recently at Stanford, and they were talking about equality and equanimity of healthcare and how that's provided, especially with AI. If the data source in itself is biased, then it's going to spew out a lot of biased information,
Yes.
which is definitely bring out a majority of the spectrum from the lower and the higher end going to be completely skewed. So important that we base it predominantly on the patient care than just on the geography. Well, we're talking about now telemedicine. That's kind of another very popular buzzword that's promised borderless care. I mean, they are looking to somehow kind of, make sure that we're able to at least cater to a lot of these people through telemedicine.
Mm-hmm.
Where did it genuinely deliver, and where did it fall short? You may be the right person to give that answer to us.
Yeah. So obviously, I've been working in telemedicine for over a decade now, for more than 12 years. And I'm a little bit biased towards telemedicine. I genuinely believe, because I've seen how it works on the inside, the frameworks and everything, I genuinely believe that telemedicine can deliver on the whole value chain of healthcare, including surgery, which is almost like a taboo that people talk about, that, oh, you can't do surgery through telemedicine. No, it's actually a domain called telesurgery, where you involve robotics and you're involved high speed. And we did actually an experiment like that 10 years ago in a sandboxed environment. And imagine now with how far we've come with telecommunications, 5G, even 6G, and robotics, it's 100% doable. But the success stories, and I would say the top three domains where telemedicine has delivered and has demonstrated tangible results, are mental health, primary care, and chronic disease management. And that's because of the volume, obviously, and obviously for mental health specifically, it's for reasons that I think are also intuitive, and they're a no-brainer, because you're breaking borders, you're breaking taboos, you're providing you're providing those stakeholders with access that is almost pseudo anonymous, that is private, that is secure, and that's why the most demonstrable success in telemedicine has been in mental health. And ironically and coincidentally, and I'm sure this has been also circulating with everyone in the domain, there has been a Harvard Business Review study that came out last year that showed that actually the most common use case for artificial intelligence is therapy. And it's for the exact same reasons where telemedicine is successful. It's because of its accessibility, it's because of that privacy, it's because it provides the patient or the user, I don't like to call them patients, but it provides the user with that comfort of not go. I mean, this is an individual who's already in trouble and who's already troubled. So adding more barriers and asking them to go to a clinic or wait in line or book an appointment or whatever is nuts, in my opinion. That's why telemedicine is doing really well in those domains. And obviously, like I said, chronic disease management for obvious reasons, because the patient is pretty much on a specific journey. You know exactly what their steps are going to be, and you can manage their journey ahead of time. It's not reactive, and that's why telemedicine has been very effective there. And we've had success stories here in this part of the world, and in these three domains, obviously, mental health, primary care, and chronic disease management.
Fantastic. And I'm so happy that you brought that about chronic disease management, because chronic disease management, according to me, especially being a health coach and a dietitian, I think is more should be always proactive than reactive. The
100%.
episodic that you give is definitely not going to enable care for that chronic disease condition, whether it be diabetes, hypertension.
Yeah.
So well put together. Thank you so much. But just alongside with the aspects of mental health, especially in the United States, where I see now there's so many guardrails, there is so many regulations.
Mm.
California just came out with regulations about laws that needs to be impeded or put together for any advisors or any diagnosis or any consultations for mental health. Is that hampering the advantage that would be provided to them, or how do we kind of wage that? I mean, how do you kind of go past it and yet kind of make sure that it's adopted correctly?
I mean, it's to us again. To us, for us in the domain. It's obvious and it's a no-brainer. But maybe to others or people who are on the outside, it's not obvious. But the solution is not to stop or to ban or to obfuscate or to put more barriers. And that's also an evolving domain that has evolved parallel to that domain of digital health and mental health. It's called cyber psychology. I happen to be working with the university here doing research in that domain. And and the whole thesis is that instead of hampering or putting regulations that actually ban, like, for example, what happened in Australia, for example, they banned teenagers from using social media. We don't believe that's the solution. We believe that the solution is to work and make the use of digital solutions, whether it's telemedicine, whether it's artificial intelligence, whether it's social media, make them useful and repurpose them in a positive way that affects users in a positive way. And that's what we believe in. And I think we're in sync with the regulators here in this part of the world. That's also their line of thinking. But obviously give the regulators in the US or wherever that happened maybe the benefit of the doubt, is because unfortunately there were some tragedies that happened from the misuse of those technologies. And the knee-jerk reaction and the immediate reaction is to stop it. It's almost and you can look at how we do it in medicine. It's like when someone's bleeding, the first thing you need to do is to stop it and then try to treat the root cause. So that's me giving them the benefit of the doubt, obviously, and I'm sure that these regulations will evolve to have something that is meaningful, and because we can't fight it, it's coming. So we might as well repurpose it for in a positive way.
Absolutely. And a very comforting answer. Thank you so much, Remy. So, what actually makes first in cross border care? Because that's, again, your specialty: technology, regulations, or trust. I know we touched about this, but
Yes.
specific.
To be very specific, obviously it's regulation, and it's I think it's obvious technology evolves way faster than regulation, and so there's no the way we see it, and I'm bullish on technology, to be honest. That's why I try to focus on the governance, because it needs to catch up. It needs to catch up to how fast the technology is evolving. So yeah, to answer your question, it is regulation. It breaks.
Now, on to a question about the patient. Can a patient truly feel safe when their care spans countries, platforms, and clinical teams? And how are you doing it in terms of your practice to give that safety aspect to the customer or to your clients?
It's an excellent question. And it's a question that we need to ask ourselves constantly, because healthcare in general, it functions on obviously safety and trust. And so how do you win? How do you win patients' trust? And I think we're getting there. We're not there yet, but I think we're
Mm-hmm.
getting there by, for example, what we do here, and we focus on not fragmenting the patient's journey. So we have telemedicine programs here that accompany the patient wherever they go, and they're tied. So patient has their family physician, for example. That family physician remains with the patient wherever they go. And we try as much as possible in terms of partnerships or in terms of providers to make that patient journey as seamless as possible wherever they are. And I think that's the key to trust. That's the key to making the patients feel safe, is that at the end of the day, you're not only dealing with the technology, you have someone behind it who you trust, who is your family physician or your preferred doctor or your specialist, who knows your longitudinal history. That's what we're trying to do now, and that's what we've been successful at to a certain extent with at least patients here in this part of the world.
Absolutely. Fantastic. So that again is definitely a big comfort for patients, especially in your part of the world, to
Yeah.
add the human in the loop in terms of bringing the primary care physician into the
Yes.
picture, which you so rightly said, they are the one who know the entire history
Yeah.
of the entire life history.
Hmm.
Okay, with mental health and chronic disease management better suited for borderless models than traditional hospital care, we kind of
Yeah.
briefed upon this. Are there any specifics, especially with telemedicine, that you're doing or adopting, any models that you're actually adopting that enables this more seamlessly for you?
I mean, obviously, the answer is a resounding yes. I mean, in fact, the goal of these programs that we adopt for either mental health or chronic disease management is actually to reduce admission into the hospital. That's the purpose and that's the objective, whether with any program in those domains, whether it's mental health or chronic disease or even primary care. And yeah, the frameworks are the best practices, to be honest, in terms of like for mental health, the best practice is obviously to try to keep the patient digital works 100% of the time and it can deliver the whole value chain. For chronic disease management, a bit of a hybrid approach. And if I had to give it a percentage, it would be maybe 70% digital or 70% virtual and 30% in person, just for those domains that require the patient to, for example, physiotherapy or a fitness trainer or even a life coach. The in person interaction also adds value. But the best practices in that is obviously the hybrid. This is how we got the best results. But I'm biased towards digital. Like I said, I believe the whole value chain can be delivered through digital. And if I had to add a little bit of nuance to it, it's a generational thing. The younger generations actually prefer to be more virtual and more digital than in person. And I think that's the right mindset because being sick, that's how I put it, even though many people don't agree with me. Healthcare needs to be transactional. You need if someone is sick, you need to treat them and move on and get them sick and get them healthy or treat their sickness in the shortest, fastest time possible. You don't want to prolong that state of misery or that state of illness or that state of sickness. Maybe transactional is not the right word, but I like to use it because it just means that we have to focus on treating the patient, getting them sick getting them healthy in the shortest period of time.
I think you've just proven your point, and I don't think there is a problem in being biased because you practice what you preach.
Yes,
So that's perfectly all right.
true.
What about the cultural sensitivity, Ramy? I think this is something we definitely need to be very conscientious about, especially in a place like Dubai,
Yes,
where part of the people are immigrants and there is huge diversity. Needless to say, the Emiratis they have their own culture, and then you've got a huge diversity of people coming in
yes,
with different professions. How do we keep that in scale, especially when it's being served in a global scale?
yes. Obviously, it's a very important, again, question, and it needs to be baked in from the get-go in any program that's created. And sometimes it turns into a bit of a tug of war between the technologists in the room and let's say, the clinicians in the room. Because the technologists, they think of creating a one size that fits all, a universal solution that fits everyone. But that's something that we keep saying in healthcare. It's not a one size that fits all. You need to tailor it you need to tailor it culturally. You need to tailor it, by gender. You need to tailor it's not a one size that fits all. And yeah, that's something we try to be conscious about in any program and we try to bake it in from the get go. And that's one of the things that technology is not going to solve. The human, like you said before, the human in the loop, it's important in that aspect, and it's important to make everyone aware that treating patient A is not like treating patient B, is not like treating patient C.
Absolutely. Yeah. I think just the comfort that you get from watching the other person being from the same culture, or wearing an attire that comforts them, that in itself is
Yes.
just simple psychology that could just kind of help them open up. And yeah, so rightly said, Ramy.
Yeah.
All right. to make sure that we also have a rapid fire for you here, I'm going to go on to the last question with my, the queries about connecting through borders or removing borders rather.
Mm.
Looking ahead, what must change for care without borders
Mm.
to become trusted and not just accessible?
I mean, there's a lot. There's a lot that needs to
I
be
know,
seen.
but
Yeah.
just name one that comes on the top of your head or
From the
two.
top of my head, I think it's the incentives. That's the one thing that needs to be, if once the incentives are aligned, not fixed, but they're aligned, everything else will follow, in my opinion. Regulation, technology, cultural nuances, everything will follow. But incentives is the first problem, and it's because it's also the most difficult to identify, and it's not the most tangible problem. So yeah, I think much of our effort needs to from us needs to be in that domain, and to try to dig deep into it, and try to crack that code.
That's very interesting you say that. I think as human beings, the psychology is that we all love to be validated. And I think incentives is one way you can definitely get validated.
Yes,
So, all right, onward to our rapid fire. I've got a few here. We'll see how much we're able to keep up
sure.
with. And then we'll AI scribe, AI diagnosis, AI governance. If you had to pick one that healthcare's getting right first, which is that?
I think it's obvious it's AI governance because it's more
All right.
inclusive. Yeah.
You worked across Middle East, Africa, and Europe. What does the US healthcare system get completely wrong about AI adoption that other systems get right?
Um, Actually, we learn a lot from U.S. systems, and I think the only problem that the U.S. does, besides obviously the misalignment of incentives, the rapid innovation without sufficient guardrails. These guardrails actually have been also revoked. They've been reinstated I think I know that it's been reinstated on a federal level. I think they're not enough, and I think that's the mismatch. But this is, I think it's a universal phenomenon. We are here trying to move regulations and governance as fast as the technology. I think in the U.S. technology growth is way faster, and the regulations and the governance and the guardrails need to catch up.
So rightly said. All right, finish this sentence for me, Ramy. Most healthcare AI pilots fail not because of the technology, but because of.
Because of misalignment.
Excellent. You've said AI is the most useful tool you've ever used, but where does it scare you? Or does it?
So far, it doesn't scare me, but it scares me when people overtrust it, when users overtrust AI, and I think we're starting to see how, when you start deploying AI autonomously, some catastrophes happen.
True that.
Yeah.
All right, two more to go. If a primary care physician came to you tomorrow and said, should I trust AI in my clinic? What's the one question you would ask them before answering?
Where are you getting your AI from?
What's one thing clinicians believe about AI ethics that is completely wrong?
It's a complicated question, but I'll try to borrow from some of the people that I admire. I think people look at AI as a tool that we need to be 100% in control of, and I think that is the wrong mindset. I think the right mindset is that we need to work with AI in parallel with AI. It might be a little bit controversial at the rate that AI is exponentially growing in terms of its capabilities. We might want to work alongside AI rather than become the masters of AI. That makes sense.
Absolutely.
Yeah.
Sure makes sense. Well, this was a phenomenal conversation. Very, very, engaging. And I don't know how the time went by. We've already crossed a
Yeah.
half hour. Any closing remarks, Ramy? I know you've been in this field and you're certainly doing something which is, everything that you said today is what you've practiced and that's put into, effect. And you're a person who's experienced in that field. And as a clinician, what are some closing remarks that you would like to share with us, Ramy?
I think that the biggest risk of technology actually is not the technology itself, it's the hype around it. And I think the hype needs to be taken with a bit of it needs to be addressed cautiously. So if I had to summarize it in one sentence, is proceed with caution.
Mm.
Yeah.
Interesting. Yeah. And I think you've put in the foreground in there already, talking about it being a little baby that's just starting to walk and crawl. So you need to take care of that baby.
Mm,
You got to be cautious and
true.
yeah, nurture
True.
it well. So well said. Okay, fantastic. Thank you so much once again.
Thank you.
It has been an absolute pleasure having you here. We're looking forward to more conversations with you. And this is Hikigai Studios for you and yours truly, Lalitha Ramamoorthy. Please join us in more upcoming conversations. We're also going to have a panel discussion soon, which is going to be inclusive with physicians, and we're going to have industrialists and technologists as a part of the panel. And I think it'll be a hot panel. So looking forward to more. Thank you, Ramy, once again.
Thank you very much. Have a great day.
Yep.
Bye bye.